Dr. Rajasekhara graduated from Yale Medical School in 2004 after working as a FAR research scholar in the lab of Dr. Robert Weiss. He began training in urology at the University of Washington, but then chose to pursue a career in image-guided, minimally invasive procedural therapy. He went on to complete a residency in diagnostic radiology and a fellowship in interventional radiology at Brigham and Women's Hospital in 2011. He thereafter returned to Yale to join the faculty as an interventional radiologist. The mainstay of Dr. Ayyagari's contributions over the past several years have been in the realm of prostatic artery embolization, PAE. He developed one of the first and largest PAE practices in the country, and in collaboration with several faculty from the Department of Urology, he's reported his outcomes in IR and in urology societal meetings and peer-reviewed journals. He's considered a leading expert on PAE and regularly lectures on the topic nationally and internationally. In recent years, Dr. Ayyagari has implemented one of the few in-bore MRI-guided prostate biopsy programs in the country. His transperineal approach significantly improves the infection risk of the transrectal approach, while allowing direct visualization and sampling of suspicious lesions seen on diagnostic prostate MRI scans. Lately, Dr. Ayyagari has partnered with Dr. Sprinkle, Dr. Preston Sprinkle, and Dr. Sandeep Arora to build Yale into one of a handful of centers in the world that now offer a new MRI-guided transurethral prostate cancer ablation procedure, a treatment that has promised to become a game changer in the treatment of prostate cancer. Thank you, Dr. Ayyagari.
Okay, thanks very much for having me. Okay, so I'm going to talk to everyone about prostatic artery embolization. Thank you very much for having me. It's kind of a bittersweet talk because I'm actually leaving Yale. I don't know, some of you may have heard, but I'm going to be leaving Yale at the end of July, moving on to Leahy Clinic. So this may be my last talk with you guys. So I have no disclosures. Just to give you a quick overview, we're going to be talking about, overview of BPH and existing treatment options, which I'm sure this crowd is very, much aware of. So I'll kind of go through that quickly. Then we'll discuss the concept behind prostate artery embolization, or PAE, and the procedural details. And then we'll go through some cases and then review some results achieved to date with PAE here at Yale. So obviously, you guys know probably a lot more about BPH than I do. BPH is a histopathological diagnosis. We also call it bladder outlet obstruction or benign prostatic obstruction. Obviously very common. Men in their 30s, few will have it, but about 80% of men in their 80s will have it. Obviously, it's not a cause of mortality itself, but has major impacts on morbidity, quality of life, and a lot of healthcare costs for a large segment of the population worldwide. And as we know, it can lead to UTIs, hydronephrosis, and even renal failure if really left unchecked. And obviously, you guys know the anatomy. This is the prostate, where it sits relative to the bladder neck, and how the prostate, when it enlarges, can cause bladder outlet obstruction. So when we talk about diagnosing BPH, obviously we use the International Prostate Symptom Score a lot, excuse me. There's 7 symptoms that we rate from 0 to 5, 0 being not bad, 5 being the worst. So these include frequency, nocturia, weak stream, hesitancy, intermittence, urgency, and incomplete emptying. And then there's the bottom, quality of life score. And then the symptoms get rated as mild, moderate, or severe. And then we'll also look at the quality of life and CHIM scores. We'll look at urine flow rates, post-void residuals, look at gland volumes, and then urodynamic studies sometimes when we need to do some problem solving. And then just some pictures of, you guys know these devices, the Uroflow device, and obviously the urodynamics diagram below. This is obviously a female patient, but just to kind of, give the schematic of how this test is done. So first, when the disease is not really severe, when it's more in the mild to moderate stage, obviously medical therapy is the mainstay. We'll use alpha-adrenergic antagonist, primarily tamsulosin, of course, some alpha-zosyn to decrease the dynamic tension of the prostatic smooth muscle. For larger, bulkier glands, 5-alpha reductase inhibitors like finasteride or dutasteride can decrease structural bulk. And these medications can improve symptom scores by 20 to 40%, especially when in combination with each other, and can improve flow rates by 15 to 25%. But of course, these medications are not without their side effects. Some patients can experience impotence and decreased libido, ejaculatory disorders, hypotension, or dizziness with the alpha blockers. And then, as you guys know nowadays, Cialis, 5 milligrams daily, phosphodiesterase inhibitor can also be used to help reduce the smooth muscle tension around the prostate and the bladder neck. And so then when medical therapy no longer is sufficient in controlling a patient's symptoms, then we move to something procedural. And obviously the TURP, the TURP, is the gold standard for invasive therapy. It's effective for more severe disease and generally for glands 80 to 100 cc's. But obviously some urologists who really facile with this procedure, can take it up to larger glands up to maybe 120 cc's. Obviously, like I said, it's the gold standard. It can reduce the symptom score by up to 70% and has unmatched flow rate improvements, but it has its drawbacks as well. Nothing comes for free anymore. It's invasive. It can be bloody and painful. It requires general or at least spinal anesthesia, typically in admission, or maybe not these days. You guys can tell me about that. Obviously, patients have to have catheter in for a few days. Not effective for the very large glands. And reoperation rates can be up to 15%. Erectile dysfunction can occur with this procedure, as well as retrograde ejaculation. And then there are also the perioperative complication rates. Need to recatheterize a patient, bladder perforation, bleeding, and infection. Obviously, these are small risks, and even smaller are the risks for incontinence, bladder neck contracture, and then renal injury and TURP syndrome, which of course nowadays is not very common at all. So kind of less invasive, but perhaps maybe a little less effective. Green light laser photovaporization has a better safety profile, but maybe less efficacious in terms of reducing symptom scores. And of course, it's also limited by gland size. So the huge glands aren't going to be really candidates for this procedure. And then obviously there's the holmium laser nucleation of the prostate, the HOLUP, which Dr. Kellner does here at Yale. It's good for the really large prostates, but obviously there are not a lot of experienced surgeons out there when you move beyond kind of the large major medical centers. And also I'll like to hear from you guys, but I've heard talks before where a lot of people don't necessarily pursue HOLUP in glands greater than 200 milliliters in size. So then there are other less invasive options. So the UroLift obviously is a popular one these days for the smaller glands. Less invasive, lower risk profile, but then maybe not as effective as the more standard procedures. You can get symptom score reduction rates of 30 to 50%, and it's a newer procedure, of course. So probably not a lot of 10-year data out there yet, but there are 5-year data. None of these procedures, of course, halt or reverse the underlying hyperplastic process. They work to kind of mechanically open up the channel and kind of remove or ablate or push back the central obstructing tissue. Then there's obviously the prostatectomy, the simple prostatectomy, which can be done in an open or a laparoscopic robotic fashion. Obviously, it's definitive, but it can be invasive, and there can be a lot of blood loss with it. And so definitely not a good option for more elderly, frail patients. So then obviously I'm an interventional radiologist. So what can IR do for patients who have BPH and fail medical management, or patients who aren't surgical candidates due to their comorbidities or their large gland size? And then there are some patients out there that are just shopping around looking for the least invasive thing they can find, while kind of getting the best bang for their buck in terms of efficacy. And then there are patients with large glands who are still very much sexually active and want to minimize their risk for erectile problems afterwards. So prostate artery embolization, or PAE, is a treatment for BPH, which kind of goes through the arteries and embolizes the gland to kind of shut off the blood flow and shrink it down. And this was first reported in 2000 by a guy named John Demerit, who's an interventional radiologist trained here at Yale, and he's actually in Hackensack, New Jersey, I think has been for the past 20-some years. So just to kind of give you a quick overview of the anatomy, this is obviously a very schematic diagram. But the blood supply of the prostate is from the anterior division of the internal iliac artery. The dominant supply is from a prostatic branch coming off the inferior vesical artery. And that obviously can supply urethral and trigone and also the seminal vesicles. And here you can see this little diagram of iliac arterial anatomy. There are several types of origins that we categorize in the IR literature of the prostatic artery. It can come from the internal pudendal, from the obturator, and from the rectal branches, as well as coming from the common trunk with the superior vesical artery. Anastomoses are really the rule in the male pelvis, and there are lots of variations, normal variations in the anatomy. So it's really important to understand this anatomy and really have these patterns, down in your mind. So that way, when you're looking at a case, when you're doing a case, you're not struggling, getting lost in the weeds, because sometimes it can be really challenging. And these vessels, even when they're very large, they are still typically pretty small. 1.5 millimeters, I think, is probably generous. Usually they're smaller than that. So how is PAE currently done? So we have lots of tools and tips and tricks to talk about, but I'll try and be brief. So we'll use these different 5 French catheters, which have all sorts of different shapes and sizes and lengths. These will be our base catheters. Then we'll use these tiny little micro catheters. They'll usually be 2 French. And this is one, it's called a Swift Ninja. It's really cool because you can actually turn the little wheel, and it's almost like a little ureteroscope. You can move the catheter around and point different directions. Costs about $2,700. These are the beads that we typically use. The brand is called Embosphere, but there are other brands out there that people use. And then one catheter, a micro catheter that I like to use, is called a Sniper. It has this inflatable balloon tip on it. It's basically like a tiny Foley catheter, but you can use this to select a vessel and then inflate the balloon so that you basically minimize or eliminate reflux of the particles back into non-target vessels. So it's a really nice device. And then sometimes we use coils when we need to plug up larger kind of communications between, say, prostatic arteries and penile branches, things like that, just to kind of protect the non-target structures, the non-target vessels, and to kind of funnel the beads just to the prostate. And we put in coils probably 30–40% of the time. So now talking about patient selection and counseling, actually, Dan Kellner wrote a paper with me that we published about a year ago, just talking about patient selection and how to work patients up. But basically, we'll just do a standard kind of BPH evaluation, history and physical, getting all these basic prostatic, like kind of function, I guess, scores, information, looking at their erectile function, the post-void residual flow rates. If there's any concern for infection, especially in patients with indwelling Foleys, we will get urine cultures. Urodynamic studies we don't get very often, mostly for problem-solving situations. Obviously, pretty much all the patients that we see for embolization have been already evaluated by you guys or other non-Yale urologists in the area. So typically, if a patient is coming for prostatic artery embolization, they've already been kind of vetted and deemed to be a candidate for some kind of BPH procedure. But there are sometimes patients that will self-refer. And when they do come to see me first, I always make sure that they go see a urologist as well, because I don't like to practice in a vacuum. And so, but every once in a while, we'll not be exactly sure what's going on, or really want to make sure that a patient's bladder is working well enough before we embark on some, procedure, be it embolization or anything else. Sometimes we'll get a CTA or an MRI to look at the actual vascular anatomy, but very rarely. I found early in my experience that wasn't really helping me make decisions about management, because these vessels, even when they're very big, they're still very small, and they often aren't very visible on CT scans or MRIs. We will get ultrasounds, or if there are cross-sectional image studies available, just to kind of estimate the gland size. But again, the gland size really seldomly affects my decision-making process in terms of if I'm going to do the procedure, how to do it. But if the patient hasn't already seen a urologist, I'll use that gland size to help counsel them about their other options. And then if they do want to talk to someone else about whole ep or urolift or whatever, I'll be able to kind of make referrals appropriately. Lots of times patients will already have been worked up for, the possibility of prostate cancer. They'll have, high PSAs coming into it. I try to keep this evaluation and this procedure kind of, in a separate lane from the prostate cancer evaluation, because I think they should proceed separately. And I make sure, again, that if that a patient has been seeing or does see a urologist, to make sure that that's also being addressed. I have embolized patients knowingly with prostate cancer to treat their BPH symptoms, some for bleeding that may have been, I guess, related to the cancer, or just from a bleeding prostate. And of course, in this age group, 65 to 90-year-old men, there will certainly be lots of patients out there with undetected or clinically silent prostate cancer. So having prostate cancer is not itself a contraindication doing the procedure, as long as we feel like it's an otherwise appropriate thing to do. So inclusion criteria, this is more for, kind of when we're doing research studies and things, but we like to, obviously make sure we're treating patients that are, appropriate for a procedure. So pretty typical criteria for inclusion and exclusion for the procedures as any other kind of BPH procedure, I would imagine. We'd like to make sure they've tried medical therapy and failed that, or if they have acute urinary retention and they can't get the catheter out, or even long-term retention. For LUTS patients, we want to make sure their symptom score and quality of life scores reveal, actual real kind of moderate to severe symptoms. We don't like to embolize anyone who has an active prostatitis or UTI because obviously the body fights infection with blood flow and with antibiotics in the blood flow. And so if we're cutting off blood flow and infarcting, tissue in the prostate, that can really set a patient up for a worsening of an existing infection. So we like to make sure those are clear. Bladder diverticula, we really don't necessarily use as an exclusion, but we just want to make sure we know, again, that the patient does have some, still reasonable bladder function left. Stones, so bladder stones, we like to make sure that there's not going to be an issue with infection afterwards. And so sometimes urologists will like to deal with the stones before we embark on an embolization. Obviously, the patient needs to be able to clot once we close up our arterial access to close off the arteriotomy site. And we are using contrast. We want to make sure the patient has adequate renal function not to get AKI from this. And then, like I said, we just want to make sure we're doing the right thing and treating a patient that has legitimate BPH that's worthy of a procedure. So the technique, it's an outpatient procedure. It usually lasts about 2 hours. The actual interprocedural pain is pretty minimal, apart from the lidocaine from getting the access. Patients don't have sensation within their arteries, so they really don't even sense us when we're working in there. They'll just feel the warmth from the contrast here and there. Usually, the bigger issue is just if these older patients with kind of orthopedic spine issues, if they have pain, or difficulty laying on their backs flat for 2 hours. That's actually probably the most common, complaint we get during the procedure. So obviously we treat them with sedation as needed, usually fentanyl and Versed. I'll give Toradol during the procedure because sometimes, especially when we get a really robust embolization, they'll start to notice the burning, the kind of the inflammation in the prostate as we get to the end. And certainly in the evening after the procedure, the night after the procedure, that's when the pain will really peak. So the Toradol helps to kind of head that off. So I'll usually go from the right common femoral artery. A lot of people use left radial artery for access, which I will do from time to time as well. For me, the femoral artery is just kind of more ergonomic based on the way our rooms are set up. And there's also one, that Swift Ninja, that microcatheter that you can use to steer and point around. That's only made in lengths long enough to go from the femoral access. It's not yet available in a longer radial access length. So that's why I like the femoral access, just to be able to use that. However we get in, we go down and get bilateral internal iliac artery access and do angiograms on both sides. We will do, once we get our catheters either in the internal iliac or the anterior division, or even more selectively into prostatic or other vessels, we'll do what's called a cone beam CTA on the table, where we inject contrast through our catheter, and the imaging device kind of spins around, and we'll do a CTA really right there on the table. And it just creates the images on the fly in 3 dimensions, and we can use all this fancy software to kind of reorient the images and do our kind of treatment planning. So it's a really useful kind of like method to use. So then we'll select each prostatic artery. Typically there's one on each side, but sometimes there will be multiple feeders on a given side. Once we get in and we confirm we're in the right spot, we will inject these beads. I typically use the smaller 1 to 300 micron embospheres for cases where I'm worried about some anastomoses or little microvascular connections. I might use the larger beads so that they don't penetrate quite as well, and therefore probably give us a lower chance of some kind of non-target complication. But usually I like to use the very small beads to try and penetrate the gland as effectively as possible, and therefore hopefully to get as good of an infarction as possible. Like I said, we often coil collateral vessels, probably 30 to 40% of the time. And then after the procedure is done, the patient goes and hangs out on bed rest for 2 hours just because of the femoral arterial puncture. We make sure they can urinate reasonably well before they go home if they don't have Foley in, and then we discharge them home the same day. Then we follow patients up at 1 month, 3 months, 6 months, then annually. For those patients who have urinary retention, we'll usually wait 1 month to do a voiding trial. Nowadays, we get lots of patients coming in from out of state. And so what we'll usually do is just have them stay at a hotel the night before, come in for the procedure, stay at a hotel. Usually I have them stay for if it's on a Friday, for the whole weekend, just to make sure we don't run into any kind of complications like urinary retention or something like that. And then I let them travel home. And nowadays, since COVID, with telemedicine really coming into play, a lot of these patients, after the 1 month follow-up, when we get into the subsequent follow-ups, it's easily done over video or phone, and we just have them get local ultrasounds to measure post-void residuals. So the follow-up is really easy, even for patients coming from out of state. All right, so just kind of a little picture there of the setup. You can see this is a radial artery case. The patient is awake, and he really wanted to watch the whole case, so he is there, kind of relaxing with his other arm and able to see the whole procedure on the screens. This is one of my fellows from a few years ago. You can see it's pretty nice ergonomically. We can just sit there working through the patient's wrist and kind of do everything, as long as they're not too tall. If they're over like 5'10", 6 feet, we worry about our devices not being long enough to make it down. But it's actually surprisingly a pretty straight shot, kind of angiographically, going from the left radial artery down to the pelvis. And these are just some selected images from a case. This is the patient's left internal iliac artery, in the left anterior oblique position, and the black arrow is pointing to the origin of the prostatic artery. And then you can see here the black arrowheads kind of surrounding the left half of the prostate gland. And this is just an unsubtracted view. You can again see the prostatic artery and its supply, and this is just a little bit of reflux into the pudendal artery there. This is just contrast, it's not beads being put in. And then here is a right half of the patient's gland, frontal view, a digital subtraction angiogram, just to show you kind of the anatomy, how it looks. And then a corresponding, this is that cone beam CTA that I said we often get. And again, this image is created on the fly, and you can see just a nice correlation between what the vessels look like on the CTA versus the angiographic image. And here on the left, we've already embolized the left side, so that's kind of staining from the beads. So we'll often get the cone beam CT at the end, if not already during the procedure, just to kind of look at all the staining and make sure we've treated the gland completely. So now I'll go through some cases. So case one, this 70-year-old with severe BPH. He'd failed medications. He'd had an indwelling Foley for over a year. He'd had multiple UTIs and bouts of hematuria, all thought to be prostate related. Obviously didn't have a symptom score, quality of life score, because of his Foley. His gland volume was 245. So this is a frontal DSA, and I don't know if you can make out, this is where his pubic symphysis is, and this is the balloon of his Foley. So already you can tell his gland is pretty big. The Foley balloon should be somewhere around here in someone with a normal prostate size. So big gland. So now we select the left side, and again, this is a left anterior oblique position, and our catheter's in the internal iliac artery here. And just to show, that's where the Foley balloon is. It's hard to make out on the subtracted image. So in the anterior division, this is his superior vesical artery. This is his internal pudendal artery. This is his inferior gluteal artery. That's his middle rectal artery, and this is the inferior vesical artery. And so what's missing is obturator. That was coming off of his external iliac, which is, again, a common variation. So we get selected with our microcatheter into the inferior vesical artery, and you can see prostatic branches there, and just kind of the left half of the prostate gland. So we embolized him, and this is an axial image of the cone beam CT, where you can see just the opacification of the vessels of the left prostate gland. So that was pretty straightforward. Then we moved to his right side. And so again, there's the Foley balloon for reference. There's the superior vesical artery. There's his internal pudendal artery. There's his inferior gluteal artery. There's his obturator artery. There's his inferior vesical artery. And we saw this little thing there, which we weren't sure what it was. So we were going to just get more selective and take a look. So we get into that inferior vesical artery. Again, the Foley balloon. There's the vessel. So then we do a cone beam CT, because we're not quite sure what that other little branch was. And so you can see, well, first of all, we stained the left half of the gland with beads. You can see here opacification of the right half of the gland. But here's the rectum, and there's this little opacification, this little vessel there. So we thought, oh, we got to be a little more careful here. So we did a different projection. To the left of the screen is the posterior, the right of the screen is anterior. This is the inferior vesical artery. This is that little purple branch, and lo and behold, this is to the rectum. And when we really injected harder, you could see that this branch was actually coming from his internal inferior mesenteric artery. So this was a rectal feeder. So we didn't want to put beads in the rectum, of course. So we put a coil in, and you can see the coil right there, right there, that little thing there. So it blocked off the branch, and those coils occlude the vessel within a couple of minutes. So we just put the coil in, wait a couple of minutes, do another run, and we look and see, and the door is closed. Now we're safe to put the beads in. So he did really well. Got his Foley out after a month, and at 12 months, his symptom score was 3, quality of life was 0. He had a post-void residual of 80s, and his gland volume gone down by about 25%. We didn't get a flow at the time, but he was doing well. And this is a picture you can actually see. He had some shrinkage of the gland tissue, kind of periurethral, so that was a nice outcome. And he had his first erection in 12 years, so that was nice. So just talking about our results for treating urinary retention, Dr. DeVito and Dr. Schoenberg and Dr. Chine collaborated with us on this paper that we got published in the Gold Journal a couple of years back, just going over our outcomes. We had some really great outcomes to show. And actually, subsequent to that paper, we just compiled more data, and we were able to get enough patients with small glands versus large glands, just to kind of show you these data. We've done about 400 patients now. These, I think, are once we had about 300 patients. And just to kind of show you, kind of stratifying small glands versus large glands. In the beginning, so on the x-axis are the months, like 0 is pre-procedural, and then, months of follow-up. Then the percentages are the fraction of patients that either red have an indwelling catheter, orange are self-catheterizing, or yellow are voiding. So in the outset, obviously, they're all with the catheter, either self-catheterization or indwelling. And you can see here as the data play out, we really get really good results with getting patients off catheters. The results probably look a little bit better for the larger glands. You can see here about 80%, even all the way out to 4 years, are able to kind of maintain a good voiding pattern. Some are self-catheterizing, and then maybe 10 to 15% fail voiding trials. What I usually tell people is about 75% overall, when you kind of combine all these patients together, will have good long-term successful voiding, after a prostate artery embolization procedure. And then just looking at symptom scores and quality of life scores after, these are in retention patients after we embolize them, and some post-void residual numbers as well. These, the N are pretty low. Again, these are kind of fairly old data, but now with hundreds of patients, we have pretty much the same data with even longer follow-up. So another case, PAE for lower urinary tract symptoms. So this was a 79-year-old male with severe LUTS. He'd failed medications. Symptom score is 23, quality of life was 5, post-void residual 200s. He had a large gland, 187. His uroflow showed an outlet obstructive pattern with otherwise pretty reasonable bladder function. He was not thought to be a candidate for surgical procedures because of his gland size, and he'd had multiple UTIs. So again, kind of just typical imaging here. We're in his left internal iliac artery and a left anterior oblique position. There's his prostatic artery, and the flow to the left half is prostate gland. This is an unsubtracted image, just to kind of give you, reference. You can see here his bladder full of contrast as he's urinating or excreting contrast in his urine during the case. So that's the vessel and the branches. And then this is he's kind of twisted here a little bit, but a coronal cone beam image. And you can see here, nice opacification of the left prostate here. And there's actually a little bit of flow around here to kind of a sigmoid colon branch, and some flow down here below towards the penis possibly. And so this just is a nice illustration of how the cone beam CTA can really help us, see things that we might not see on the digital subtraction angiogram. So in this case, we just got more selective, and then we had that balloon microcatheter where we inflate the balloon, and we're able to really just funnel the beads just to his left prostate. So then we moved over to the right side, and you can see there we put some coils there here to kind of close up those collaterals to the penile and bowel branches. On the right side, we select the vessel. This is the right half of the gland, and that's a nice kind of magged up image. And you can see, I believe you can see my mouse here. That's the vessel going up to his bladder. This is his pudendal, and this is inferior glute. So this was another case where the balloon on that microcatheter really helped. We were able to kind of get in just the prostate and deliver the beads there. So that's another coronal cone beam image of that. So at 3 months, his symptom score was down to 6, quality of life was down to 0, post-void residual was really, almost, nothing. And his gland volume shrank basically to half its size. And he had a pretty good urine flow rate after. And these are just some images, pretty much the same, axial slice. And you can see how much his gland shrank. He had a complaint afterwards. You can see, obviously the corpora here of his penis. He felt like his penis shrank afterwards because his gland shrank so much. It seemed like they had been pushing on things so much that his penis actually the configuration kind of changed a bit. So I didn't really know how to counsel him on that. I thought it was a result of a good infarct, but and he otherwise was doing fine, but it just was something he noted. So we published our results with lower urinary tract symptoms a little while back, again, with Dr. Chai, Schoenberger, and DeVito contributing. And again, these are older data. We have much larger cohorts that we've reported lately. But again, this just kind of shows the symptom score and quality of life score improvements we can achieve with PAE. Our patients on average have about a 22.5 symptom score. We usually get them down to somewhere around a 7, 6 to 8 range. And that's kind of that. Now we have data out over, probably going to publish our 5-year data this summer. And likewise, quality of life score drops nicely. And so then again, these are more recent data, probably with about 300 patients, again, stratifying large versus small glands. Again, the same timeline on the bottom, 0 is pre-op up to 48 months. And so the green patients are patients who come in with mild IPSS, yellow or moderate, red or severe. And you can see obviously in the beginning, lots of severe and moderates. And again, it looks like maybe the larger glands fare a little bit better over long term in terms of the fraction of patients who are able to stay in the mild range. But overall, when you look, average out the actual symptom scores, we get about 67 to 70% reduction in the IPSS maintained over 4 years now. And this is looking at post-void residual and gland volume reduction after PAE and LUTS patients. A lot of grains of salt here with these data because they are with transabdominal ultrasound, but we do get pretty good post-void residual improvements and gland volume reductions. When we've looked more carefully at patients who do get cross-sectional imaging, we have seen about a 30 to 40% reduction in gland volume on average. This is just a busy slide, but basically at one point we looked at gland volume, age, and comorbidities to see if those would predict any better or worse chance of having good outcomes. We looked at symptom score reduction. We looked at quality of life score reduction. We looked at post-void residual reduction. And bottom line is that there were no significant trends here. So we use this to kind of counsel patients that regardless of the gland size, the age, or the comorbidities, they were otherwise would be have a good chance of success after the procedure. So what about doing this for gross hematuria? This is a case of a patient who had severe gross hematuria. An inpatient got referred to us, who'd been on CBI and getting transfusions. And so we're in the left internal iliac artery here. We do our angiogram. And this is what we call an empty pelvis sign. There's all of his posterior division, and he's got his pudendal, his inferior gluteal artery, his obturator artery, and this is pudendal, very ratty, a lot of atherosclerotic disease. He's got nothing feeding his bladder or prostate that we can see. His vessels are just kind of closed down. So then we went over to his right side, and here you can see we've selected already the prostatic artery. He's got bladder with some contrast. He's got a Foley in because he's on CBI. And you can see contrast getting through and getting through to his left gland. So sometimes we'll see one artery supplies the entire gland. And so that's the prostatic artery that's crossing through the right over to his left gland. And you can also see there's a little penile flow down there. So we have to be very careful in this case. So we get across. And you can see as we start embolizing, the beads are really soaking his left gland and not really his right gland much at all. But then as we kind of finish with the left gland, then we get the beads kind of backfill to the right gland. And luckily at this point, we weren't seeing that penile flow really anymore at all during the case. So we were okay with that. So here we're filling up the right half of the gland. And he did well afterwards, stopped bleeding. And again, this is, I think I already showed this, but we published our data in the Gold Journal also on gross hematuria. And so again, very similar looking curve. This is again with about 300 patients at this point, looking at patients who present with gross or severe hematuria, this is in patients with CBI going. And again, we stratified small glands versus large glands. In the small gland group, we really had no patients that presented with that severe picture, kind of in patients coming in, on CBI, getting transfusions. In the large gland group, of course, we do have those patients, and in our series here, about 15, almost 20% were those type of patients. But you can really see we get, probably of all the things we use PA to treat, hematuria is probably the best. We get the best effects afterwards. You can see here, patients really clear up after embolization. Very, very few patients have any hematuria at all afterwards. Maybe one or two had severe hematuria that required going back to the OR for fulguration or something like that. And a lot of these patients with the persistent hematuria were actually on blood thinners, so like stroke patients or patients with cardiac valves who already have some blood thinning on board. So really great results with embolization for gross hematuria. And so just a little quick case here. We're in the left side. You can see his inferior vascular artery feeding his prostate. And sometimes you'll get these branches. So this is a branch coming off his internal pudendal artery, going all the way around to his right side. And we were able actually to get all the way from left all the way back around to right. And so you can see here, here's his bladder. Here's the right half of his prostate. There's probably going to be penile flow down here. So this is our that sniper microcatheter with the balloon. So here we've inflated the balloon there to kind of protect against reflux back down. So we embolized his right side from his left side. And here's just a kind of a cone beam CT image kind of showing the whole acrobatic, effect there. It was a pretty cool case. And then this is another case. So this just shows you, what you're really getting into and what you really need to be looking for and when you should use your judgment and stop. This was a patient with a pretty small gland actually. And here, it's a complicated picture, but basically he has a Foley in and there's contrast in the balloon. This is the Foley catheter. We've actually gone radial access here and we've got our microcatheter in his left, and I'm not even sure, I guess it was like a common trunk, inferior and superior vesicular, but we're injecting contrast. You can see blood flow in his bladder. This is collapsed bladder around the Foley. There's blood going down here to, presumably his prostate there. Here are the connections down to what will be internal pudendal artery feeders, feeding towards the penis. There's blood flow across from left to right, both inferior and superior vesicular. And it literally flows right through just with a very, kind of minimal hand injection all the way through to the right side into his internal iliac artery branches there. So just with one little squeeze of a catheter, you can see these collaterals, they're all over the place. And so one really has to be careful navigating this anatomy and just knowing when to stop, obviously. And so this was a case where we said, there's no way we can do this safely. And unfortunately, this is, again, really hard to predict because CTAs and MRIs just won't really show this anatomy in detail enough to really make those predictions. But another just interesting kind of spin on all this. We looked at, and this was kind of Toby Chai's idea actually originally. We took a look at our LUTS patients, and we wanted to see if we had any differential improvements in voiding versus storage domain scores after prostate artery embolization. And obviously, you guys know the voiding sub-scores of the IPSS, the incomplete emptying, the intermittency, the weak stream, the straining, versus the storage scores, the frequency, urgency, and nocturia. And when we looked at all of these, this is a very busy slide. We just kind of, in our LUTS patients, kind of looked at all 7 scores and how they improved over throughout 3 years. Obviously, we had nice drops and then kind of sustained improvements over 3 years. When you look at just kind of normalizing these so they're kind of comparing apples to apples, the voiding score domains dropped better or more so than the storage. So and this was statistically significant and persistent throughout 3 years. So we definitely saw an improvement more in the voiding than in storage scores. And I believe that's also seen in maybe the TERP literature as well. When we looked at our retention patients, we obviously don't have pre-procedure IPSS or quality of life scores, but you could see that their mean symptom scores were nice and low all the way through from 1 to 3 months to 3 years. And again, we saw an improvement, or I should say a lower voiding scores compared to storage scores in retention patients, again, all the way out through 3 years. And the 3-year data point was just short of statistical significance, probably just because of the lower cohort size. But so overall, what we tell patients, About 7 out of 8 LUTS patients will be happy with their results with about a 2/3 reduction in their symptom score and quality of life score. About 75% of urinary retention patients will get back to reasonable voiding pattern with reasonable post-void residuals. We often are able to stop patients on the BPH medications, almost 2/3 of them. Some of them will stay on them empirically. Usually more it's the patients with the larger glands who will keep on the finasteride just to kind of make sure that glands don't kind of grow back. We usually get, like I said, about 30 to 40% shrinkage in glands. And like I said, with the gross hematuria, about 95% of patients just stop bleeding. Some continue on with some mild hematuria, and very, very few need, anything else done. So these are our adverse event rates over 350 cases. And I won't go through all this. You can kind of, see what we have to say here. But basically, the one thing to look at is, so the LUTS patients, about 5% of them will go into retention afterwards, just because of, some kind of swelling. Usually, these are the patients who are kind of on the edge of retention anyway. We have had, and probably Dan Kellner knows this the best, a small portion of patients will pass necrotic tissue. 7% are the ones that have reported it and noticed it and said, hey, this is I saw this happen. There's probably more than that, passing little small specks that they may not even notice. But these are patients that have passed pieces of necrotic prostatic tissue that are large enough to perceive. Sometimes they'll actually have to push them out like they're passing a stone. And then there have been a handful of patients, maybe, I don't know, 4 or 5 patients that have had actual chunks passed that were so big that they kind of got blocked up, kind of had a little ball valve effect, and then the patient kind of had to come in urgently for a catheter and then have a cystoscopic kind of removal of that tissue. I think Steve Schoenberger's probably seen 1 or 2 of these cases as well. We've had about, actually now in about 400 cases, we've had about 8 patients have issues with some ischemia to the skin of the tip of the penis. I think 6 of these have been very mild, just like just a little abrasion, and kind of cleared up after a couple of weeks without any need for any intervention. We've had 1 patient that had more of about like a quarter-sized area that kind of basically like had a big scab that sloughed, and it took that a few months to heal, but it did without any issue subsequently. And then we've had 1 patient, I can't remember, I think Dr. Portman had referred, who actually had he had a hypercoagulable state, leukemia patient. He didn't want to take his blood thinners, heavy smoker, a lot of bad peripheral vascular disease. He had 1 tiny little hair of a vessel feeding his penis, and we got definite, ischemia to the glands of his penis after that. And that he did slough some tissue, and that was, definitely a complication that, caught all of our attention. But he had a Foley, and at the time he got rid of it. He was pretty happy. He said this was a cosmetic issue, but then later on he did end up having to go back to having a Foley, and I think because his bladder was really small and just kind of contracted. But unrelated deaths, we've had I think 3 patients who died. 1 patient came back with a fungemia about a month after the procedure. 1 patient had a fall and died at home the next day. We don't exactly know why, but he had no evidence of any issues related to the procedure, either ischemic or infectious, that we were aware of. And I think actually we had 1 more patient in that tissue damage category that maybe, I don't know if Pat Kenny's on the line, but he was a patient that had gross hematuria afterwards and had some ischemia at the skin. But I think that got better, but then he unfortunately succumbed to, he had a large stroke already before we did the embolization, and he passed afterwards. And otherwise, in terms of bladder and rectal ischemic issues, I don't think we've ever really had anything happen to the rectum. We had 1 patient afterwards who just seemed to have pretty significant, severe, ongoing storage symptoms, and they just didn't get better after the embolization, but it didn't seem like he had an overactive bladder picture, so that may have been something, but it was really unclear. But a very, very low percentage of patients overall that have any kind of ischemic complications. And just talking about other things we do to try and kind of make the procedure safer and easier. I know I'm kind of getting short on time here. This is just an illustration of how we use that balloon catheter. You can see here, we're in a prostatic artery. It's a pretty big one. And you can see this is the prostate here. These are branches feeding seminal vesicle and bladder. If we get beads to reflux, you can see where they might go if we weren't careful. We inflate the balloon and then we do the same injection. You can see now we've excluded outflow, reflux, and then we were able to embolize safely. But then also, like I said, these collaterals are everywhere. This is some branch that showed up later on in the case, going down to the internal pudendal penis. So you just have to be really, really careful with these cases. And that just shows, though, that our symptom score improvements, like our and quality of life and post-operative visual, really didn't improve with this catheter. It's not like it helps us embolize better; it just helps us embolize more safely, I think. And then we're doing all sorts of things, trying to kind of calculate gland volumes and figure out to correlate embolic particle volumes with gland volumes to see if we can kind of predict how much beads we should be getting into a patient, just to, again, to help us be effective but safe. And we also looked at our learning curve. We looked over 300 cases, and we saw over about the first 50 cases, we just got faster and more efficient with the procedure. But when we looked at the amount of beads we injected, we didn't see really any difference from case 1 to case 300. So our embolization was probably as effective from the outset. And this really played out when we looked at 6-month, symptom score and quality of life changes. We got good numbers from the first case all the way to the last case in the series, and likewise with gland volumes and post-operative visual reductions. So really, and these are hematuria and retention treatment failures on the bottom and successes at the top, and then our complications, claving into complications over our case series. So we really felt like while with increasing experience, we got faster at the case and more efficient, more technically proficient, but our clinical outcomes were the same, from the beginning. And this is just a look at our case volume increases, the number of referring urologists and self-referrals over these years. Then we had I didn't compile the data over the past 3 years, but we basically leveled out about 90 to 100 cases a year, with a dip obviously during the initial COVID wave when we stopped all elective cases. And so take-home points is a patient of candidate for PAE. Basically, anyone who's failed medical therapy and is not a surgical candidate, either because of comorbidities or gland size. Obviously, indwelling Foley patients are good, for these procedures, as long as the renal function's okay. Any patient who might want to get a TURP, be getting a TURP, but might bleed a lot, patients on anticoagulation, kind of DVT, stroke, cardiac valve patients. And then anyone who is having, severe gross hematuria, oftentimes patients on anticoagulation can present with hematuria. If there's a long wait list, I know I've heard other people who do PAE who work at the VA, they'll get a lot of referrals because you guys are busy, and trying to get patients in for TURPs at the VA can be really long waits for patients. Embolization doesn't really burn any bridges. So if you embolize someone and they have a great result, great. If they don't, they can still take any BPH medication. They can still undergo any other BPH surgery they'd otherwise be a candidate for. And in fact, shrinking their gland down and cutting off, most of the blood flow can make those procedures safer and easier. And then obviously just patients who want something less invasive. And that's about it. Thank you. And I just wanted to say, I think I mentioned in the beginning, and some of you already know, I'm going to be moving on from Yale. I'm going to Leahy Clinic at the end of July. So kind of wrapping up things here. I've been here for 11 years, and I've been doing this procedure for 10 years. And really, I owe you guys a lot. It's been great working with you. And all the way, I remember I gave a grand rounds on this probably about 10 years ago, and then right afterwards, Dr. DeVito came up and referred the very first patient to me, and it's been it's just been a great experience ever since. And I really thank everyone for all the collaboration and all the the referrals, and it's just been wonderful working with you guys, and can't say thank you enough. This is my my email and my cell phone, personal email, personal cell phone. Obviously, I'm going to be not having my Yale email for much longer, so please. Don't be strangers. Please keep in touch. And if you ever have any patients that you want to refer, I'd be happy to treat them. I'm still trying to figure out some way to kind of carry on my legacy here and have someone else take up PAE, but it's obviously a big project, and trying to kind of train someone up. So that's to be continued. I'll let you know how that goes. And that is the end of my talk. Thank you very much.
Hey, Raj, this is Dan Kellner. Can you hear me?
Yeah.
Hi. Yeah, that was an excellent talk. I'm sorry, I didn't know you were going to be leaving. I'm sorry to see you go. I think there's a certainly a good role, and there's been good collaboration. And so you'd mentioned before, you weren't sure if we did prostates over 200 cc's with HOLEP, but it's really size independent. I mean, I think our largest prostate we've done so far, the tissue is 450 grams. So you could do any size prostate. But as you said, it doesn't hurt to do a PAE first for these large prostates. And what I found is if I had to do a HOLEP or other surgery after PAE, there was less bleeding. I don't think it complicated anything.
Yeah.
So one of my questions for you is are there predictors of who's going to slough? Just because from my own observation, it seems like it's usually the middle lobe that seems to slough.
Yeah. I've been trying to look at that just within our own series, and I've not. The problem is it's been there not have been enough patients to really come up with anything kind of statistically significant. In the literature that exists, again, I think it's still kind of uncharted territory, and because I know we do a lot of patients that have large median lobes and don't slough, or at least that we can detect. And so I wonder also if it's more of a if we're able to somehow get a more complete infarction in some rather than others. I just don't know, not yet. We don't have enough patients to really figure it out yet. I will say, I think the smaller glands don't. I think it's definitely the bigger gland. The smaller glands it's not that bulky tissue that will, kind of slough and come off. So I could say probably smaller glands won't, but that's about all I can really say.
Is there a minimum size that you would not treat? Because I mean, some of these prostates, it's not the size of the prostate, it's really like the bladder neck or the shape of the prostate.
Personally, no, but I definitely, I'd say the average gland size I've treated is, I mean, when I put everyone together, it's about 150. And so the patients that come in to see me that are under 80 are, I'd say it's maybe 10% of my overall referral base so up to date. And I definitely counsel them heavily on they're having other options. And so a lot of those patients usually that I see in clinic usually end up not getting PAE because they come and see you for UroLift or they have something else done. But I've treated patients as small as 35, and I haven't seen any difference in overall kind of the quality of outcomes. But I do think I actually didn't show. I have some data that I think the technical failure rate is probably higher in the smaller glands, and overall my technical failure rate is about 5%. There's probably 3% of patients where I only do a unilateral embolization because I can't get in one side for whatever reason, and about 2% of patients where we just don't get in either side. And I think the smaller the gland, the smaller the vessel, and the more technically challenging they can be. So the technical failure rate is slightly higher in the smaller glands. I will say the complication rate is slightly higher in the larger glands. So it may just be that the smaller glands, are a little bit harder to get into. But again, the cohort is small. It's about 40, 50 patients. So it's hard to make really strong kind of conclusions on that.
Hey Raj, Harris Foster.
Hi.
Sorry to hear you go. I actually sent you a 91-year-old patient. I think you may have seen him recently.
Yeah, yesterday.
Yeah. So good luck where you're going. My question is, do you have experience with retreating people? That is, people who have not done well initially. And what were your criteria for retreating? How did you decide to do it, and what were your results?
Sure. So I've only retreated of my own patients. I've retreated maybe 8. So it's going to be anecdotal data test. So I've had a few patients I retreated for gross hematuria actually. I want to say 3, and offhand I can remember 2 of them. They did really well. So they came in initially with gross hematuria, like CBI, the whole thing. But also had pretty significant BPH symptoms. We embolized them, they stopped bleeding. They did really well symptomatically also for years. And then 2 of them, I remember they came back again with severe hematuria, and they were still doing well symptomatically. And so I can't remember, I think these were St. Raphael's cases. And so you guys didn't call me initially because it was like everyone thought, oh, they've been embolized, they've been doing well, but they're bleeding. So they went to the OR, got scoped, tried to fulgurate them, couldn't get the bleeding to stop, but they saw the gland have been shrunken and necrosed. And so again, no one thought to re-embolize, but then bleeding kept going. So someone gave me a call, and I got back in, and lo and behold, the arteries looked like I'd never been in there. They reopened, they recannulized. And we think that happens a lot in any embolization that we do over years. The vessels themselves, like the trunks, reopen. So in those cases, I re-embolized them, they stopped bleeding, and they did well. Now I have had probably 5 or 6 patients where it's more like a LUTS, like where they get worse over time. And they're going to be treatment failures with anything, of course. And I found that when we correlate their increasing symptom score with either an increase in post-war residual, or maybe not if they still have good bladder function, but a bona fide increase in gland size over the a few years, that those patients are saying, well, okay, now it's time to consider doing something again. And now I'm happy to go back in and retreat to see if we can. But obviously, if you feel like embolization didn't work for you and you want to try something else, go for it. And I make sure they come back and see whoever they saw before from urology. But I'm always happy to try and retreat because it's so low risk and so easy to go in there and check. And of the patients I've retreated, again, it's a small number. I would say half did really well afterwards and really got back to a really good spot with their symptom scores, and maybe 3 or 4 of them, they got better, but not great. And so sometimes I wonder if there are just some glands that are less susceptible to, the ischemia than others. Obviously there's technical issues that can come up. Sometimes the beads can clump and you don't get a really good, soaking of the gland with the beads. I will say I've retreated maybe 5 or to 10 of other patients treated elsewhere at other centers. And some of them you went in there and it was like they never got in at all, and we retreated them and they did great. Some of them, they did a really good job and there was very little extra to do, but we just did a little bit more and they did better. So overall, I think there's really very little reason not to try and retreat if they have a bona fide resurgence of symptoms. Obviously, I think they need to be aware of their other options. And there's very little harm. I'm not sure it's the best result in terms of symptom score reduction and all that. So,
Raj, Dinesh Singh here. Nice work. Strong, innovative thought process there. But I wondered if you could comment on, I run Journal Club and we always talk about how there's biases and series and all these things, and randomized trials are the things that hold the most weight in really telling us what the truth is in the different things that we do. And EU is our highest impact journal in urology, and they had a randomized study with interventional radiologist neurologists that they looked at over 100 patients who were randomized to either embolization or TURP. And their findings were that the improvement symptom scores were clinically and statistically inferior to embolization, and the retreatment rate was up to 21%, which was significantly higher than TURP with embolization. And I thought that catches the eye a little bit because there's so little things that are randomized, and that was a randomized trial. And I wanted to see what you thought about that.
Yeah, so that trial, if I think we're talking about the same one, it had its issues. One, the gland volumes were very small in that study. I think they were all under 80, and a lot of us feel like I think I alluded to, the smaller glands may not do as well as the larger glands. So I think that study kind of missed the mark from hit the patient population that we think PAE is really the best for, like the larger glands, the patients with who aren't great surgical candidates, or TURP candidates, I should say. And also there's a lot of there's not a lot of people in the world doing PAE, and there's a lot of debate on what's the proper what's the best embolic agent, or what's the right embolic endpoint. And so there are questions about, at least from the IR side of things, how did they really quantify their embolic endpoints? Did they use the right agent? Did they, like I said, were they selecting patients, ideally? As you said, there's very little like really good quality, level 1 data out there comparing, PA to other procedures. There's a good, also published in European Urology, is a really good sham study, just kind of trying to lay the groundwork for this. But it's been a real problem because it's really hard to do randomized trials to compare, because a lot of people say, well, should we compare PA to TURP? Well, a lot of people in IR think not, because really what we should maybe comparing PAE to is to the HOLEP, the patients with the, like I said, the really large glands. So I think that study, it didn't really go as far as we would have liked, because I think, again, it wasn't the right patient population to study for this. There are a couple of other really, pretty poorly done randomized controlled trials out there. Low numbers, not, really well designed. So that's one thing that we're actively, we've been working on, and Harris can really comment on this too. Working with the AUA, trying to come up with some study design that will satisfy everyone and deliver, really good, data that can then be used to kind of, be referenced in guidelines, things like that. But it's a real problem, because it's really hard to get these things funded or to then enroll patients, because when you try and randomize patients, there was a randomized trial that was started, must be 10 years ago, 8 years ago, and it had like 8 or 10 centers throughout the US, but they really had trouble randomizing, because patients, if they wanted one thing and they were randomized the other, they would just drive up the street, from New York to come to New Haven or Boston to get whatever else they wanted. So it's a big challenge.
So the average age in the study was about 68, and the average gland size was about 52, which I would say mirrors the prototypical patient who comes to see us for BPH. Are you saying that PAE should not be used for the typical patient and should only be used for those very large glands?
I don't know if I'd make such a strong statement, but I think definitely, I think its sweet spot is definitely for the larger glands. I wouldn't say it's not appropriate for the smaller glands, and definitely we get, I see patients who are very focused on their sexual function and don't want anything to happen to their sexual function. And hey, let's try PAE first, and if it works, great, and if it doesn't, I'll talk about a TERP or green light, whatever. So, but and my experience has been very skewed to the larger glands, naturally, just from referral patterns and the patients that need this. But I do, when I see a patient who comes in under 80 or under, I really say, well, this is one option, here are the other options, know about everything, and really make your own decisions, and obviously see a urologist. But I really do feel like the large glands, like over 120, is really kind of where this procedure fits best.
Raj, it's Tom Buckley.
Hey.
Quick question: are you tracking PSA and as you do younger patient, how this impacts our screening for prostate cancer? And have you seen any de novo cases of prostate cancer after PAE?
Yes. So, well, let's see. Formally tracking PSA, no, because what one, it's just really hard to just from a resource point of view to kind of be tracking all that. Two, they're usually getting it anyway, because you guys are following, kind of just screening them appropriately. We do find, so I don't formally get it myself. They usually have it before, and I looked actually one of our just retrospectively, I looked at post PSAs, and something like 70% of patients had them. We see that the PSA usually drops to less than half of what it was preoperatively, and commonly it'll go down to like 20%. But what I tell patients is, we're infarcting obviously the the periurethral tissue, the central gland, and obviously a lot of prostate cancers show up in the periphery of the gland. And so I'm very careful to make it very clear that no one should think of this as a cure for prostate cancer. That while we are shrinking the bulk of the gland and really helping with urine flow, they still need to undergo their like age appropriate prostate cancer screening. I do tell them that they can expect their PSA to drop by quite a bit typically, and that they shouldn't really interpret that as good or bad, just a new baseline. I tell them not to get PSA checked within 3 months after, because if you check it a day after, it's going to be 1,000 or whatever. But I like to let it settle out till the gland is shrunken down, which is usually about a 3-month period. And then I just tell them to get it rechecked and just to keep on with the urologist and just to use that as their new baseline. We have seen, definitely we've seen prostate cancers come up in patients after embolization. And like I said, I've certainly treated patients with prostate cancers that we knew about, and then they were they were like on active surveillance, and they just kept going, and they get biopsies, they get MRIs, and it didn't really affect their cancers too much. I mean, there are some studies out there, one really poorly designed, really, I think they should have ever even done it, where they tried to do chemoembolization for prostate cancer, which I just think was really off the mark. I try and keep the lanes separate and just tell patients, just assume they're going to have whatever, like to continue their prostate cancer screening and just kind of keep it as separate, like kind of things in their mind.
Raj, one of the more, even though it's, I know you've said it's rare, kind of one of the more notable complications is the penile ischemia.
Yeah.
I mean, especially, I think because sometimes the procedure is discussed as one that's sexual function preserving. How does that conversation with the patients go when you say, like, listen, there's a few % chance that you're going to have some penile ischemia or necrosis? I mean, what is that?
I really show them the same numbers and kind of tell them the same thing that I told you guys. Like I tell them, I think it's probably anything like serious ischemia. I say it's probably less than 1%. And then it's all about full disclosure. And a lot of patients, and I tell them, actually, I'll tell them specifically about those specific cases and really describe to them, kind of how things played out with those patients. And I'm just very frank about it. And I think overall, lots of times these are patients who, they're just too sick, or they're not going to be, for whatever reason, they're not really considering these other, like a TURP or HOLEP anyway. And so for them, they look at, I tell them to look up, or I give them my, interpretation of the surgical complication rates. And I give them the data. I say, I tell them to make their own decisions and conclusions about it. In terms of the actual, the sexual function piece of it, we've had maybe 1% of patients describe, and I haven't been very good at like really, following this well, but about 1% of patients describe some decrease in erectile function afterwards. And anecdotally, we have, and again, this is obviously really hard to study, but probably about 10% of patients notice an improvement in erections afterwards. But when I tell people, the bottom line is, in terms of erectile function, it's very, very, very low chance they'll have any impact and negative impact, and maybe some positive impact. But again, not proven or it's anecdotal, and we don't know why that happens. And I do tell them, in terms of ejaculations, the semen volume will go down just because we're shutting down prostate tissue. And I'm just very I just give them the numbers and explain kind of just compare and contrast with their other options and let them decide.
I've always been interested by kind of your anecdotes about how erections can improve in some patients after this. What do you think the mechanism of that is? I mean, especially when some people are getting penile ischemia, and I would think they'd have erectile dysfunction.
Well,
what's the
ischemia,
mechanism for embolization leading to improved?
We don't know, but I mean, the penile ischemia cases, that's when beads, get down the vessels and basically get down to like, the very distal, the glands, and cause like disruption of blood flow to the soft tissues there. I mean, obviously erectile dysfunction is going to be more like, like a neurological problem, right? And so I think infarcting nerves, I think really it just doesn't seem to happen. It would be a different kind of, I don't know, like geographically within that, the anatomy, it'd be a different way the beads would go, or just, I don't know if it's really possible to like infarct nerves, it seems with the beads. And so I think of those as two, like, I almost don't think I just don't even know, but I don't think erectile dysfunction, when it does happen, is really necessarily an ischemic problem. I don't know how better to explain it. Why people will get better, I think that's even more of a mystery. I think, and you guys know better than me, obviously, but I remember hearing people talk about anytime you do something that improves urination, I don't know if it's a psychological thing or it's a blood flow or what, but that people just will sometimes just feel like better about things, and maybe it's more just a psychological thing, like I said, where they get better erections. I definitely have had people just call me and say out of the blue, I haven't had an erection in years, and I woke up this morning and there it was. I don't know if it's also maybe a pressure thing, maybe by decreasing the bulk or decreasing the pressure on the vessels and the nerves, going to the penis, the neurovascular kind of structures, or maybe if it's even a rerouting of blood. If blood was getting shunted into this big hypervascular, meaty prostate that's now, got other places to go. I don't know. So,
I know we're getting late. One more question, Harris.
sure.
There's a lot of discussion about progression of disease. Do you have any data on how many of the patients who did well, maybe it's sort of similar to my last question, go on to have surgery? Because, you talked about patients staying on medications or going back on, but have you ever, the ones that did well, any idea if any of them ultimately went on to surgery? Like if it just delayed progression? Almost like
Well,
the
actually, you made me sorry, one thing you made me think of, going back to Pat's question. Also, like I mentioned, a lot of these patients, we do get them off their BPH medication, so that may also help with the obviously the improvement in erectile function. So in terms of progression, I think it's really hard to predict, and I don't know if it's if you can say larger glands, smaller glands. The numbers in terms of people who've come back after having a good result and then kind of gone back to a bad result, I want to say it was about 5%. I say overall, like my patients who go on to have something else done, be it surgery or repeat embolization, I think the minority come back for embolization and the majority go back, go to have something else done, because that's usually what I tell them, like, you should just look at all your options, and embolization maybe didn't work for you. But it's been, I think, 5, maybe somewhere between, I'll say between 5 and 10%. I don't know the numbers offhand. So probably, over 400 patients, it's probably, about, I don't know, 20 to 30 patients, somewhere in there. But it's more of a lot of patients, those who just don't have a good result to begin with. The LUTS patients primarily. All right. Any other questions? Okay, well, thanks again, everyone. Really appreciate it's nice to kind of, talk to everyone, see everyone again, one last time. And again, thanks for everything.